Hello, and welcome to One World, One Health, where we take a look at some of the biggest problems facing our world. I'm Maggie Fox. This podcast is brought to you by the One Health Trust, with bite-sized insights into ways to help address challenges such as infectious diseases, climate change, and pollution. A One Health approach recognizes that everything on this planet, the animals, plants, and people, and the climate and environment are all linked. Nothing demonstrates how everything on this planet is linked like the problem of antimicrobial resistance, the rise of drug-defying superbugs. Bacteria especially have outmaneuvered human efforts to fight them. We've done quite a few episodes of One World, One Health looking at the problem. In this episode, we're chatting with Dr. Otto Cars, a professor of infectious diseases at Uppsala University in Sweden and a co-founder of REACT, Action on Antibiotic Resistance. It's a global network of researchers, physicians, and other experts working to educate the world about the problem and to help find better ways to fight it. Otto, thank you so much for joining us.
Thank you for having me.
You've been educating people about these dangers for many years now. Can you tell us a little bit about how long you've been at this?
Well, it's a long story, really. I've been engaged in antibiotics and antibiotic resistance for many years as a young infectious disease doctor first, and also a researcher on antibiotics and antibiotic resistance. And then moving into policies in Sweden, where I was working on behalf of the Swedish government together with colleagues for many years on a strategic program for antibiotic use and resistance. But that also led to engagement internationally, like the WHO, the World Health Organization. Already in 2001, the WHO had a global strategy for antimicrobial resistance published. But unfortunately, it wasn't widely implemented, it wasn't financed, and there was only a very small team at WHO at that time working with this critical issue. So I think that what happened was that we invited WHO to discussions and also with colleagues in Sweden and abroad, and we asked ourselves if there was a need for an independent international network to come around to try to push this issue forward, and I think the answer was yes. And that is how REACT Action Antibiotic came about. And we are working with, as you say, with education, but we also work and try to help countries in the South, in Latin America, in Asia, and in Africa.
It's not as if people haven't been clear. Again, you've been working at this. WHO, even though maybe it was a small effort, has been saying since 2001, this is an urgent problem. Why is it so difficult to get the world to listen and act on it?
First of all, the situation is much better now than 2001. When the Global Action Plan was published in 2015, that was a trigger. The momentum was really increasing, and we're doing much better now, although for sure we are still far from where we should be in managing this crisis. But I think one of the causes for the answer to your question about why we haven't gone so far is really the language that scientists are using, the language that governmental and international organizations are using. It's really, really technical and contains a lot of acronyms like AMR. It contains a lot of bacterial names. And I think that hampers a lot the understanding in the general public. And I recall a recent study that was done from 2019 to 2021 on the outreach on social media, on Twitter, like X today. And they could find that 70,000 engagement was on AMR. Simultaneously, another crisis we have, the climate change, caused interactions like 3.5 million tweets. So, I mean, there's a wide dimension in how this is picked up in social media and reaching out to people. So I think this need to change, and should have changed long ago, really. We need to include social scientists, behavioral scientists, people, anthropologists in this, how we describe this. I think we need to move from this technical language towards something that is more patient-centered. We're talking about diseases, what's really at stake here, diseases that both people and politicians know about and understand and recognize. So that's really one thing. And the other thing is why we're doing this. We have to keep antibiotics alive, to guarantee access to these life-saving medicines, which is what people think they trust, and we trust. We count on these medicines to work, but we see how they're one by one is losing effect. And then, of course, a lot of discussions need to take place in countries. These need to be contextualized, their culture, their beliefs, and so forth, all the way. But generally speaking, I think we need to have much more efforts to reach out for awareness raising and understanding.
Okay, what you just said is music to my ears. I've been fighting against the use of these acronyms and kind of academic jargon like antimicrobial resistance, which is really hard for people to kind of get their heads around. Do you have a suggestion for some better words or some better language to use?
No, that is the problem. I think there is really no one size fits all here. I think we just have to make people understand that this is about diseases that they know about. It's like pneumonia, wound infections, also infections caused during operations. All this that we are seeing, where we see the need for antibiotics in healthcare, where people believe that they will be available. This is the message that we have to convey. It's really difficult to say that we cannot express it in one sentence or in one word, unfortunately. It needs to be a little bit longer than that.
You've spoken about the irrational use of antibiotics. Can you tell us a little bit about what you mean when you say that?
Yeah, that's important that you bring this up. I mean, first of all, if we need to look upon effectiveness of antibiotics as a global resource, maybe even a scarce resource today, which we need to take care of and be responsible for together all over the world. So having said that, of course, then we need to use them responsibly. We can call it rationally, or we can call it anything around those terms, appropriate, and so forth. It's difficult to have a very specific definition on this, but if we talk about the rich countries, we could do better. We know that a lot of antibiotics is still used, which is not necessary for viral infections, for cough and colds, for influenza and other infections where they have no effect, and also for diseases which are self-limiting, where antibiotics should not be a primary prescription. And I think the higher income countries need to take a stronger lead, and they could do better. So in that respect, irrational means not for the right purpose, and maybe not the right antibiotic, and maybe not in the right dosing and so forth also. But it's much more difficult to discuss this when you come to a resource-limited setting, for sure, where there is a weak health system, where we need to have antibiotics accessible without a prescription because there are so few doctors to prescribe. So we have what we call an excess versus access dilemma. We have to recognize that. So we cannot sort of put the same demands on these resource-limited countries. We need to support these countries with the development of their health systems, and we need to secure access for everyone, including them. So in that respect, irrational could be a quite different thing. If you, for example, have a mother with a feverish 2-year child in her arms, maybe walking for 2 hours to a rural health center, and the diagnosis is unclear, you can't say, come back tomorrow if you're not better, or this is not working. So we have to acknowledge that there must be some kind of overuse, although these countries also need to try to take as much responsibility as possible for controlling the use.
Drug-resistant bacteria can cause some trouble in really surprising places. One of them I've seen you talk about is in cancer patients. Can you talk a little bit about the trouble that they cause in people getting treatment for cancer?
Yes, absolutely. I think that is really worrisome because if we see antibiotics as pillars, cornerstones of any health system, they build up the basic healthcare with common infections in the society, but also anything around high specialized medicine, operations, transplants, etc. And not the least, modern medicine, including cancer. Many of the bacteria that we see today causing sepsis, for example, bloodstream infection, is coming from our own microbiome, the flora that we carry around in our gut, for example. During a cancer treatment with radiation or cytostatic drugs, we reduce the immune defenses, and these bacteria can be transported into the blood. This could also happen, of course, with a big operation. But for cancer, we have seen in studies now that up to 10% of cancer patients are in fact dying from sepsis, not primarily from their cancer. And these sepsis cases could, of course, an increasing amount of them will also be difficult to treat because of resistance. So modern medicine is at stake. Basic medicine is at stake. In fact, we could see antibiotics as a natural component, an infrastructure of all health systems, because without them, we will have really, really much more morbidity and mortality than we see today.
That's the fear, that we won't have antibiotics that we can use to treat people who are getting treatment for something else. How did the COVID pandemic damage efforts to control antibiotic resistance? Has it affected these efforts?
Yeah, absolutely. Both ways, both positively and I think also negatively. But I would like to take up the positive examples first, because I think what happened during COVID, it raised tremendously rapid understanding of how important health and health systems are. and the need for prevention, the need to have access to treatment and so forth. So it really put global health much higher up on the agenda than before. And I think we could benefit from this when we're now trying to mobilize more action and awareness around antibiotic resistance. So another positive effect of COVID was I would say, unprecedented rapid collaboration around innovation of diagnostics, vaccines, and also treatments. This was mind-blowing, really, and we need to have the same kind of feeling of urgency when we talk about the need for these kind of technical tools, treatments, vaccines, and diagnostics also for antibiotics. So I think we can benefit from that. On the downside was, of course, that just because it's difficult to diagnose a bacterial infection, many patients with COVID got antibiotic treatment without needing it. So there's a figure around 10% of patients with COVID had superinfection with the bacterial pneumonia, but up to 75% really had antibiotic treatment. So that has for sure, at least in the short term, driven resistance in the hospital setting forward.
And in order to deal with all of these things, a lot of people, including you, say you need a national action plan. What should something like that look like?
The real good thing is that following the Global Action Plan in 2015 and just a few years after, very many countries took the responsibility to produce a national action plan. And in fact, I think the figure now is that more than 170 of the world countries have a national action plan. The problem is that only 10% of these plans are fully financed for implementation. So, having said that, it's of course a national responsibility to put all the elements in such a plan together, but it's a huge effort and it's a long-term journey, especially for the weakest economies. We need surveillance, we need antibiotic access, we need regulation, we need education, we need water and sanitation. I mean, it's really building up a health system, especially a system for access to these drugs within the health system. So it couldn't be done in 1 year or 5 years. It's a continuous effort. I think what is happening now is there are plans, but unfortunately many of them are still sitting in the ministries and there is little implementation. The possibilities for implementation are weak because of lack of financing and also human resources. So that needs to change rapidly.
And you've got some hope that the United Nations might be able to help with all this.
I think there was another meeting in 2016, which was fantastic because this was the first time where antimicrobial resistance was coming up to the highest political level in the world. And we saw a great number of countries were actively involved in producing this political declaration that was a result of this meeting. And it contained a lot of what needed to be done and a lot of commitments from government. There was some political will, but unfortunately these commitments on financing, on research and development and so forth has not been implemented in the pace that they should have. So my hope is that this time, in September 2024, the temperature will be higher, the understanding of the urgency will be higher, and the commitments will be stronger and more concrete. And I think, again, that if this political declaration could contain a common global vision, that would be helpful. It could be reducing the mortality from the resistant bacteria. It could be, again, securing equitable access to these fantastic medicines that we rely on. Financing for implementation of national action plans, as I mentioned, need to be a strong component, and not the least a supporting mechanism for the weaker economies, because the rich countries need to take the lead, like climate change, to support the transformation of the systems that need to be improved. Then we need financing for research and development. And I think the level of global collaboration need to increase, because this is an area where we have lost a lot of time. It's really, we're using old technologies. There are new ones. We need to speed up global collaboration and get the antibiotics, vaccines, and diagnosis that we need up to the forefront of a global collaboration. You can even have the form of a global research institute or some kind. Water and sanitation in all health systems could save a lot of lives, and that should be a priority. And not the least, which was missed in the last declaration, we need to have a very transparent accountability mechanism to be able to follow up the commitments that governments has made this time.
Otto, thank you so much for joining us.
Thank you so much for having me.
Listeners, if you enjoyed this podcast, please share it. You can learn more about this podcast and other important topics at onehealthtrust.org. And let us know what else you'd like to hear about at OWOH@onehealthtrust.org. Thanks for joining us.
Thank you for listening to One World, One Health, brought to you by the One Health Trust. I'm Ramanan Lakshminarayan, founder and president of the One Health Trust. You can subscribe to One World, One Health on Spotify, Apple Podcasts, or wherever you listen to podcasts. Follow us on social media at One Health Trust, one word, for updates on One World, One Health and the latest in research on One Health issues like drug resistance, disease spillovers, and the social determinants of health. Finally, please do consider donating to the One Health Trust to support this podcast and other initiatives and research that help us promote health and well-being worldwide. Until next time.